Anatomy of the oral cavity. So, when we study about the anatomy of the oral cavity, in this lecture, we have to learn some specific things. So, our objectives will be to describe the boundaries of the oral cavity, to state how these structures in the oral cavity are adapted to perform its functions, and to state and identify the muscles forming the floor of the mouth, name and identify the deciduous and permanent dentition, state the development and eruption times of teeth and its relevance in aging. And then you have to outline the macroscopic and microscopic features of the structures in the oral cavity, including the salivary glands. So in this lecture, I have brought these macroscopic and microscopic features into the relevant areas according to the areas we are going to discuss. Okay. So first, let's see what are the parts of the mouth. So there are several parts. From outside to the inside, we can see the lips. Lips are the ones in the oral, in the mouth, which contact with the outside environment. Then comes the teeth. So you have two rows of teeth, lower rows and upper rows. Then comes the tongue. Tongue is the muscular structure which is situated in the middle of the mouth. Then comes the palate. Palate is the area which forms the roof of the mouth. Then there are salivary glands. There are several salivary glands situated in the both sides of the mouth. Then there is the oral pharynx in the farmost inner side of the mouth. Then we are going to learn about the boundaries of the oral cavity. So this oral cavity extends from the vermilion border of the upper and lower lips. What is the vermilion border? It is the border you can see where the lips and the skin of the face meets. The place where the margin of the lip situated. So you can see that in a different color, and you can feel that when you touch your lip. That is called the vermilion border. So the oral cavity extends from that vermilion border to the palatoglossal folds immediately in front of the tonsils. And the boundaries, when we talk about the boundaries, anteriorly, the oral cavity is, its margin is the lips. Then the posteriorly, the palatoglossal folds and the isthmus. Superiorly, palate, hard and the soft palate. Superiorly, anterior part is the hard palate and the posterior part is the soft palate. Inferiorly, anterior to the, there is your tongue. inferiorly, there is your tongue and the floor of the mouth. So in inferior part, inferiorly posterior part, you can see the tongue, anterior to the third of the tongue. Inferiorly anterior part, you can see the floor of the mouth. And then laterally, you can see your buccal mucosa and cheeks. Then let's see what are these organs you can see and their functions, and what are the adaptations these organs have to give their maximum functions. So first one is the tongue. So what are the functions of the tongue? Tongue is very helpful in talking and articulate speech, and to grasping and moving and helping to swallow food. So for this function, it has very fine adaptations. What are those? The tongue has very delicate movements, and it is a muscular organ without bones. So what is the importance of being an organ without bones? The tongue can move and bend to any direction without being obstructed. So it has very delicate movements. Then another function of the tongue is taste and sensation. So the tongue has several taste sensatory function: sweet, sour, such as very high taste sensation. So the area which is specific for taste sensation is the mucous membrane of the tongue. For that, this mucous membrane has adapted with highly sensitive taste receptors or taste buds. So these taste buds are the receptors which are specifically adapted to receive several tastes from the foods and give sensation or sensory stimulation to the brain to identify those tastes separately. And then another function of the oral cavity is the to provide an emergency airway in dyspnea. So when you are in a difficult situation to breathe from your nose, suppose you have a blocked nose, or if someone is blocking your nose, say someone is pinching your nostrils and you can't take air from your nose. So what happens? Reflexively your mouth opens and you begin to inspire from your mouth. So likewise, your oral cavity or your mouth starts to act as emergency airway in dyspnea. So the adaptation is mouth provide a bigger air hole than the narrow nostrils. Then another function of the oral cavity is the exploratory sensation. This is a very highly exploratory sensation is very highly acquired or very highly used in neonates and small children. They use what? They use their lips to explore anything and everything they come across. They put everything in their mouth. They put they take everything they come across into their mouth and explore those things with their lips, because their lips are very highly sensitive, and during early life, the lips are the place children get most of the exploratory sensation about the things they encounter in their environment. And another main function in the oral cavity is chewing food. Teeth are the ones that support for chewing food, and for that, teeth are covered in hard enamel. So teeth can chew very hard food. And then another function is biting and cutting food. For this purpose, teeth are specifically adapted as incisors. So these incisor teeth have adapted as sharp blade or chisel shape. They are shaped into a blade or a chisel shape. So they can cut into food. And when it comes to canines, canines are function as holders, so they tear food. For that, they have adapted as cones or pyramid shape. Therefore, they can hold into food and tear them. And premolars and molars shaped as roughly flat surface, and they have cusps on their crowns, so they can chew and grind foods. And then, apart from these things, we have salivary glands in our mouth. So they produce saliva. This saliva used to moisten and lubricate food. And also, they used to bind the footballers into a very good footballers that will help and that will facilitate passing food from oral cavity to stomach via the esophagus. And also this binding food into a bolus will be also facilitated by lips and tongues by their coordinated movements. Then we come to the lips. So the lips are two fleshy folds. They are very fleshy folds. They surround the oral orifice, the orifice of the mouth. So the shape of the lips are differ from individual to individual, and the color is mostly pink color, but it can slightly different from individual to individual. And the outside of the lips are covered by the skin, and the inside is lined by the mucous membrane. So the lip is formed by the orbicularis oris muscle and the muscles that radiate from the lips into the face. And the upper lip has a shallow vertical groove on the midline that is called the philtrum. And this philtrum is seen on the outer surface of the upper lip. In the inner surface, there you can see the labial frenulae. So this labial frenula is the thing, the medial folds of mucous membrane you can see in the inner surface of the lips, both on the upper lips and the lower lips. That labial frenulae connects the lips to the gums. Okay. So when we come to the oral cavity, then as we have mentioned earlier, the mouth extends from the lips to the oropharynx. So you can see this cross-section picture. It extends from the lips to the oropharynx. So the oropharyngeal isthmus is the place where the oral cavity separates from the pharynx, the place where the entrance into the pharynx, which is formed by the paratogosal folds on the each side. So you can see the paratogosal folds or the arches in the second picture. You can see them on the each side of the mouth, like small arches, like small two arches. Then the mouth can be divided into the vestibule and the mouth cavity proper. So first we will discuss about the vestibule. So the vestibule is the part which is this vestibule of the mouth is the part which is situated in between the lips and the cheeks externally and the gums and the teeth internally. That means simply it is the place between the teeth and the cheeks. So that is the place where you keep food until you chew them. අපි අර කියන්නේ හක්කේ තියාගෙන ඉන්නවා කියලා. ආන් ඒ වගේ ඔයා කෑම ටික තියාගෙන ඉන්න තැන. So this vestibule communicate the exterior to the oral fissure between the lips and this between the lips. So and the mouth proper behind the third molar tooth on each side. So it is more likely a space which has two holes on the anterior and posterior sides. Okay. So in this hole, the lateral wall is formed by the cheek and it is lined with the mucous membrane. So the important thing about the vestibule you have to remember is that the duct of the parotid salivary gland opened right opposite to the upper second molar tooth. This is important because if someone comes to you with bleeding or pus discharge on the area of this opposite the second upper molar tooth, you have to think about something wrong with parotid salivary gland. That is the importance of knowing the place of opening of this parotid duct. Then let's talk about the oral cavity proper. So this oral cavity proper part is the place we can see interior to the teeth. The structures lie between the teeth. So it has main two parts, roof of the mouth and the floor of the mouth. So as I mentioned earlier, the roof is formed by the palate. So the palate has two parts. Anterior part is the hard palate and the posterior part is the soft palate. And the floor of the mouth is formed by the anterior two-thirds of the tongue and by the reflection of the mucous membrane from the sides of the tongue to the gum of the mandible. So, in this picture, you can see some parts of the floor of the tongue. So, you can see there is a frenulum. Frenulum means the frenulum of the tongue is the one, a fold of mucous membrane which connect the undersurface of the tongue to the floor of the mouth. So, on the either side of the frenulum, you can see the deep inguinal vein in slightly blue color. And here you can see a small swelling on either side of the frenulum, which indicate the position of sublingual gland. It is called the sublingual fold. So, and on the other side of the frenulum, you can also see the place of submandibular duct opening. So, these are the important structures you will see on the floor of the mouth. So, there is something called plica pregliata, a fold from the either mucous membrane lateral to the frenulum. So, it's just to know. And this is a picture. You can see how the submandibular and sublingual gland situated under the floor of the mouth and how the submandibular duct comes alongside the sublingual gland and opens on either side of the frenulum. And now I have previously mentioned parotid gland has a separate duct. So here you can see submandibular gland also has a separate duct. But sublingual gland, it has small several ducts which opens into the floor of the mouth. Then you have to know about the muscles of which form the floor of the mouth. There are two main muscles. First one is the mylohyoid muscle, which you can see in this picture laterally. this lateral muscle, you can see the muscle fibers in transverse fibers, and the anterior belly of digastric muscle, which you can't see in this picture. So you have to know a bit about this mylohyoid muscle. So this is the principal muscle of the floor of the mouth. This muscle originates from the mylohyoid line on the medial aspect of the body of the mandible. So it inserted into the median raphe and into the hyoid bone. It forms a curved sheet-like sling which support the tongue. You can slightly touch it when you touch your lower part of the lower part of the floor of the tongue from outside, below the chin. You can touch your mylohyoid muscle, and it constitutes the boundary between neck and the oral region. Then let's go to the nerve supply of the oral cavity. So when we talk about the nerve supply, it is easy to describe it according to the regions. The roof is supplied by the greater palatine and nasopalatine nerves from the maxillary division of the trigeminal nerve, and the floor is supplied by the lingual nerve, buccal and inferior alveolar nerves of the mandibular division of the trigeminal nerve. So as a whole, the trigeminal nerve is the one which supplies the oral cavity. But for the taste fibers of the tongue, it is the chorda tympani branch of the facial nerve is the one which carry the taste fibers to the tongue. Okay. When it comes to the cheek and the lips, the sensory fibers supplied from the buccal branch of the mandibular division of the trigeminal nerve, and then mental branch of inferior alveolar nerve, infraorbital branch of maxillary nerve. Motor fibers comes from the buccal branch of the facial nerve. In this picture, you can see some of these mentioned nerves and how they travel on the face to reach their destinations. Now let's move on to the teeth. So you know, humans go through two phases of teeth. First one is deciduous teeth and the second one is permanent teeth. So deciduous teeth are the ones which comes first. They begin to erupt about 6 months after birth, but rarely some children have 1 or 2 teeth when they deliver, but they do not continue to have teeth just after birth. And these deciduous teeth all will be erupted by the end of 2 years. So the usual time is about 6 months to start of the eruption, but that may be varied. among individuals. So you have 20 deciduous teeth, 4 incisors, 2 canines, and 4 molars in each jaw. So you have to roughly memorize these time durations when you will get your deciduous teeth. During 6 months, lower central incisors. During 7 months, upper central incisors. 8 to 9 months, lateral incisors. 1 year first molar, 18 months canines, 2 years second molars. But there are some children who will have all 20 about by the end of 18 months or 1 year. That are exceptions. So, as a rule, in deciduous teeth, and the teeth of lower jaw will usually appear before those of the upper jaw. In permanent teeth, you will have 32 permanent teeth, 4 incisors, 2 canines, 4 premolars, and 6 molars in each jaw. So these permanent teeth will begin to erupt at 6 years of age. So the first one to erupt are the first molar and first incisor. So your deciduous teeth will fall. The first incisors will fall, and your first permanent incisors will appear with alongside with first molars. Then by the age of 12 years, around 12 years, your second permanent molars will appear. So among these permanent tooth, the last tooth to erupt is the third molar. This will happen between the ages of 17 and 30. But there are some individuals who will not have their last 2 or 3 molars in their lifetime. So maybe they have to undergo surgeries and remove them to prevent later dental problems. So you have to again remember the roughly these years of permanent tooth eruption. Around 6 years the first permanent molars, 7 years central incisors, 8 years lateral incisors, 9 years first premolars, 10 years second premolars, 11 years canines, 12 years second permanent molars, 17 to 21 years third permanent molars. So here also your teeth of the lower jaw will appear before those of the upper jaw. And the important of these times of teeth eruption are very important clinically and in forensic interest, because they are useful milestones in a child's development, and also they are very important in forensic in being of forensic interest, because when say you are a JMO and you have encountered a dead body. You say, let's see, it's not a dead body, you have encountered a skeleton. So there's no clue whether this is a male or a female, or whether which is the age of this deceased. So then this eruption of teeth is very important, because the number of erupted teeth is can be used to determine the rough age of this of the person when he's been dead, or let's say he or she been killed. So it's very important to know about the time or age of tooth eruption. So when we talk about the macroscopy of teeth, so roughly each tooth is fixed in its socket by the periodontal membrane, which is called the periosteum. So there is it is a radio translucent dark line seen around the tooth of the root of the tooth on the radiography. So you have, when you see a cross section of the tooth, you have a part outside the bone and part inside the bone. So when you consider the part outside the bone, you have the enamel. The outermost part is the enamel, and then you have the dentine, and then you have the pulp. It's where it is the pulp is the place where you have your nerves and the vessels. Okay, in the part where which is in the bone, you have the root. Inside the root, there is the root canal, and the root is covered by the cementum. Okay. Then here you can see the shapes of this various tooth. The incisor, canine, molar, and premolar. The incisor and the canine has roots with one root. Molar has 3. Premolar has 2. That is how you identify those 2 when it is separated from the skull. This is a picture of a tooth microscopically. You don't need to have a very thorough knowledge of microscopy of the tooth. It's just to know and remember how it will look like. Then you have to know something about development of the teeth. So this enamel crown is developed from the alveolar epithelium, ectoderm, and the pulp, dentine, and cement is developed from the mesodermal connective tissue. Blood supply to the tooth comes from the inferior and superior dental arteries. And nerve supply, the most of the dentine and all the enamel and the cementum have no innervation. So that is why you can, that is why when you can bite into hard things without hurting your teeth much. If you don't have dental caries, you don't feel pain when you bite into things now. But to the root and the lower part, you have innervation. For the upper teeth, a plexus formed by superior alveolar nerves gives nerve innervation, and for the lower teeth, nerve supply comes from the inferior alveolar nerve main trunk. Then let's move on to the tongue. So I have mentioned earlier, tongue is a muscular organ without bone. So it can bend into any direction it wants. So let's say in specific, it's a mass of striated muscle covered with mucous membrane. So this tongue or this vessel mass attached to the styloid process and the soft palate from above, and the mandible and hyoid bone from below. So the anterior part is mobile and free. And there is a median fibrous septum which divide the tongue into identical right and left halves. And it has a very distinct, highly specialized mucous membrane. So its upper surface and the lower surface is different in terms of its functions and its structure. So in the upper surface, you can see a V-shaped sulcus in the when it comes to somewhat posterior. So this sulcus is called as the sulcus terminalis, and this divides the upper surface of the mucous membrane of tongue into anterior and posterior parts. At the point of the V, there is and at the point or at the apex of the V, there is a small pit. This pit is called the foramen cecum. And this foramen cecum is an embryological remnant of the thyroglossal duct. So in this picture, you can see this sulcus terminalis here. Most of the time when we open our mouth, the part we see clearly is this anterior two-third, this part. The posterior two-third part is difficult to see if we do not protrude our tongue outside. So this one is this area is the sulcus terminalis. Here, this is the foramen cecum. This arrow has gone straight. It has gone somewhat upper, but this apex of the V is the area where foramen cecum is situated. Okay, so the other thing you have to remember is the anterior two-thirds of the tongue is full of papillae. So this papillae we can divide into three forms: filiform, fungiform, and velate. These are the filiform papillae, these small ones. These small ones are filiform papillae. These somewhat large, scattered ones are the fungiform papillae, and the larger ones which arrange into row alongside the sulcus terminalis are the velate papillae. And in the posterior third of the tongue, there are no papillae. But it is an irregular surface that irregularity is caused by the underlying lymph nodules. That lymph nodules are called the lingual tonsil. Then we come into the inferior surface of the tongue. So I have previously short and described you about this. That inferior surface, you have this midline frenulum, and on the either side of that you can see the deep inguinal vein, and then you can see the sublingual fold, then the submandibular duct orifice, and then plica fimbriata. Beside the deep inguinal vein, you can see the mucous membrane fold, the plica fimbriata. Then let's move on to the muscles of the tongue. So when you describe about the muscles of the tongue, we can divide them into intrinsic and extrinsic muscles. So the intrinsic muscles are the muscles which are confined to the tongue. They are situated inside the tongue and they are not attached to a bone. So they are consisted of these longitudinal fibers alongside the tongue and transverse fibers and these vertical fibers. These intrinsic muscles are supplied by the hypoglossal nerve and they act to alter the shape of the tongue. So I think you all have tried to alter your tongue's shape. Many people can alter the shape of the tongue. So that action is made by these intrinsic muscles. And the extrinsic muscles are the ones which are attached to the bones and the soft palate. So they are the genioglossus, hyoglossus, styloglossus, and the palatoglossus muscles. So you can see those genioglossus. These are the genioglossus muscles. It has anterior, middle, and posterior fibers. And the hyoglossus, this yellow one, and styloglossus, this pink one, and the palatoglossus, this orange one. All these muscles are supplied by the hypoglossal nerve. So the blood supply comes from the lingual artery, tonsillar branch of facial artery, and the central pharyngeal artery. Venous drainage goes into the internal jugular vein. So I have put all these muscles, origin, insertion, nerve, and action to a table to you to remember and for quick reference. Then you can go through that table later. Then we can go through the lymph drainage. So lymph drainage is differ from the tongue's lymph drainage differ from part to part. The tip of the tongue lymph drain to the submental nodes. Sides of the tongue, anterior two-thirds of the tongue, drain into the submandibular and deep cervical nodes, and the posterior third drain into the deep cervical lymph nodes. Then the sensory innervation, anterior two-thirds sensory innervation comes from the lingual nerve branch of the mandibular division of trigeminal nerve. Taste sensation comes from the coda tympani branch. And in the posterior third, both general sensation and taste come from the glossopharyngeal nerve. So this picture shows the tongue's taste map. So the tip of the tongue gives the identify the sweet taste. That is why when we taste some sweet things, you stick out the tip of the tongue, not the middle part. So there are some specific movements of the tongue and respective muscles for that actions. So the main actions are the protrusion, retraction, depression, retraction and elevation of the posterior third and the shape changes. So you have to know about these actions and the respective muscles because they might come on MCQs. Protrusion is caused by the genioplexus muscles on both sides acting together. So retraction occurs by the styloglossus and hyoglossus muscles on both sides acting together. And depression occurs by hyoglossus muscles on both sides. Retraction and elevation occurs by styloglossus and paratoglossus on both sides. Shape changes by the intrinsic muscles. Then let's talk about the mucous membrane of the oral cavity somewhat deeper. So this mucous membrane is a stratified squamous epithelium. This oral mucosa is a stratified squamous epithelium. It is also called as a moist lining. This moist lining can be broadly categorized as masticatory mucosa, lining mucosa, and specialized mucosa. So, this diagram shows where these mucosa components can be seen. So, masticatory mucosa can be seen on the hard palate and the vestibule. Specialized mucosa can be seen on the tongue. Lining mucosa can be seen on the rest of the oral cavity. So, this masticatory mucosa is the one which is keratinized. Because mastication is a process where you will encounter with food or foreign material, your mucosa will be traumatized. Therefore, to protect the mucosa, the mucosal lining is keratinized. So the place where keratinized masticated mucosa will be found is gingiva and the hard palate. The specialized mucosa is found on the dorsal surface of the tongue. So in this specialized mucosa, you will have taste buds for the taste sensation. And non-keratinized lining mucosa can further divided into two, loosely attached and firmly attached. Loosely attached non-keratinized lining mucosa can be seen in floor of the mouth, vestibule and alveolar mucosa. Firmly attached non-keratinized lining mucosa can be seen in soft palate, ventral surface of tongue, cheek and lip. So, when we talk about the microscopy of the tongue, we have to know about the papillae. So, there are 4 types of papillae: fungiform, filiform, circumvallate, and foliate. In human, you can see three types of papillae. Those are fungiform, circumvallate, and filiform. So the filiform papillae are the most numerous type of papillae. They have dense supporting tissue core with a heavily keratinized surface projection. So you can see here the keratinized epithelium here. And the fungiform papillae are the scattered papillae among filiform. They are scattered among the filiform papillae and they are small, red and globular. They have a thin, non-keratinized epithelium. They have a richly vascularized supporting tissue core. That is why they are seen in red color among the filiform papillae. Then you have circumvallate papillae. The circumvallate papillae situated immediately anterior to the sulcus terminalis as a row. They are the largest papillae, but they are the least common and they contain numerous taste buds. So you can see this is a circumvallate papillae and this is a place where you can see taste buds. This is a picture. A taste bud is magnified and there are another gland called von Ebner's gland which are open into the base of the circumvallate cleft. So this von Ebner's gland secrete a watery fluid. This watery fluid helps to dissolve food constituents. So this circumvallate papillary epithelial wall has a stratified epithelium and it has numerous taste buds. So I think you can remember I have mentioned that posterior third of the tongue is devoid of papillae, but it has an uneven surface because of the underlying lingual tonsils. So this lingual tonsil also has overlying stratified squamous epithelium and it has these epithelial crypts and these lymphoid tissues, these tiny round things are the lymphoid tissues, and also this lingual tonsil contributes to the Walde's ring. Now let's move on to the palate. So palate, you know palate, there are two parts, hard palate and the soft palate, and these two parts form the roof of the mouth and the floor of the nasal cavity. So the hard palate is the one which is situated anteriorly and the soft palate is the part which is situated posteriorly. So the hard palate is formed by the palatine processes of the maxillae and the horizontal plates of the palatine bones. And it's continuous behind with the soft palate. The soft palate is a mobile fold attached to the posterior border of the hard palate. So in this picture, you can see the hard palate in the red color and soft palate in yellow color. And this free posterior board of the soft palate has a conical projection called the uvula in the midline. So you can see in this picture here, this conical shape free structure is the uvula. And the soft palate is continuous at the side with the lateral wall of the pharynx. And it has mucous membrane, palatine aponeurosis and the muscle. So this mucous membrane covers the upper and lower surface of the soft palate. And the palatine aponeurosis is a fibrous sheet attached to the posterior board of the hard palate. So it is formed by the tendon of the tensovilli palatine muscle. And there are 5 muscles which form the soft palate. Tensovilli palatini, levatovilli palatini, palatoglossus, palatopharyngeus and musculus uvulae. So when we talk about the nerve supply of the palate, the great and lesser palatine nerves, nasopalatine nerve and the glossopharyngeal nerves are the nerves which supply the palate. And the blood supply is given by the greater palatine branch of the maxillary artery, ascending palatine branch of the facial artery and the ascending pharyngeal artery. All the lymph goes to deep cervical lymph nodes. Soft palate has smooth movements. Raising of the soft palate occurs by the contraction of the levatovilli palatini on each side. So, there are several actions comes together, such as the upper fibers of the superior contractor muscle contract, and then posterior pharyngeal wall pulls forward. Then alongside that, pharyngeus muscles of the both side contract. Because of that, palatopharyngeal arches pulled into the medial side. And then what happened? The nasal part of the pharynx is closed from the oral part. So the closure of the pharyngeal isthmus occurs during the production of explosive consonants of the speech. So I have put another table for you to study regarding the muscles of the soft palate, on origin, insertion, nerve supply and the action. So you can study that during the anatomy reading time. Then we can move on to the salivary glands. So there are 3 pairs of major salivary glands. What are those? Parotid, submandibular and sublingual. So apart from them, there are several minor salivary glands. But the 3 glands I have mentioned earlier are the major salivary glands. They secrete saliva in response to parasympathetic activity. So salivary secretion can be induced by physical, chemical, or even psychological stimuli. But minor salivary glands secrete saliva continuously under local control and they keep the mouth moist. So first, let's talk about parotid gland. Parotid gland is the largest salivary gland in our body and it is composed mostly of serous acini. And it lies in the deep hollow below the external auditory meatus and the behind the ramus of the mandible in front of the sternocleidomastoid muscle. So it has two lobes, superficial and deep. These two lobes have divided by the facial nerve. So the facial nerve enter the parotid gland from behind and divide into two lobes and divide into its 5 branches inside the parotid gland and leave the parotid gland as 5 branches. So that is a clinically important fact. The another one is the parotid duct. So I have mentioned earlier the parotid duct enters the vestibule of the mouth opposite the second upper molar tooth. So the nerve supply to the parotid gland comes from the glossopharyngeal nerve, lesser petrosal nerve, otic ganglion, and the auriculotemporal nerve. In this picture, you can see how the facial nerve enter the parotid gland and how its branches divide inside the parotid gland to reach their destinations. And this picture shows the relations of the parotid gland. See its close relations into the internal carotid artery, internal jugular vein, vagus nerve, and the sympathetic chain. Then the submandibular gland. So this gland is a one which has a mixture of serous and mucous acini. And it lies beneath the lower border of the body of the mandible. So this also has two parts, superficial and deep. And these two parts are divided by the mylohyoid muscle. And this deep part of the submandibular gland lies beneath the mucous membrane of the mouth on the side of the tongue. So, I have mentioned earlier the submandibular duct opens into the floor of the mouth at the side of the frenulum. So, nerve supply comes from the facial nerve via the chorda tympani and the submandibular ganglia. Then comes the sublingual gland. So this also has both serous and mucous acini, but mucous acini are the ones predominating. And the sublingual gland lies beneath the mucous membrane of the floor of the mouth. That is why there are two sublingual folds we can see in the floor of the mouth, close to the frenulum of the tongue. So there are several sublingual ducts directly open into the mouth of the summit of the sublingual folds. Nerve supply comes from the facial nerve via the chorda tympani and the submandibular ganglia. So when we come to the microscopy, so you have to study the salivary secretory unit. So this is a tubuloacinine structure. So it is composed of either exclusively serous or mucous secretory cells, or it can be mixture of both serous and mucous types. So when it is a mixture. You can see serous demilutes. What are so here you can see the serous demilutes. They are the semilunar caps formed by the serous cells around a mucus acini. So these secretory units are covered by myoepithelial cells. So they can be contracted and push the secreted saliva into the ducts. And the intercalated ducts are lined by the secretory cells, cuboidal secretory cells. Then they passed into the striated ducts, and these striated ducts are lined by the lined also by cuboidal to columnar cells. So this secretory cells secrete isotonic fluid, but in the striated ducts, this hypotonic saliva is produced from this isotonic fluid. So this is a microscopic picture of a parotid salivary gland. So you can see it has numerous lobules, each containing many secretory units. These units mainly of serous secretory units. So this is a picture of submandibular salivary gland, and it is a mixed. It has mixed seromucous secretory unit, serous demilutes. You can see here mucus acini with the serous demilute. This is a picture of sublingual salivary gland. So it has predominantly mucus acini and has occasional adipocytes. So in a summary, we have discussed about mouth. A small introduction, its functions of the mouth, its parts, gross anatomy, muscles, blood and nerve supply, then about teeth and its development, tongue, palate, and the salivary glands. So, now that after the lecture, you have today you have physiology reading time now. So tomorrow you will have anatomy reading time after the physiology lecture. Neither. So someone answer. Okay. Then you can go through this lecture again and collect some MCQs and SAQs given from this lecture. Then try to find answers for those MCQs. Then you will able to remember the needed exam points, answer points then and there. Okay. So, any one of you have any questions? No.
Madam, are the von Ebner glands a serous gland?
Sorry.
The von Ebner glands, I think you mentioned it in the palate section. Are they a serous gland?
You have asked, are they serous glands?
Sorry, do they produce serous secretions? Yeah.
That I'm not sure actually. I will find out and let you know. Okay.
Okay, thank you.
What is the exact type of the gland. I will let you know.
Okay.
Okay, okay. Then anyone have any other questions? Then thank you. You can refer for histology part, Peter's histology, and for gross part, you can have Snell's. So last is also okay. Then thank you everyone.
Thank you, madam.
Thank you.
Thank you, madam.
Thank you, madam.
Thank you.
Thank you, madam.